Neither the El Paso County Medical Society, its members, nor KCUS-TV shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
4, 3, 2, 1.
What is a traumatic brain injury and just how serious can it be? According to the CDC, a traumatic brain injury, also known as a TBI, which we'll talk about tonight a lot, is a disruption in the normal function of the brain that can be caused by a bump, blow, or jolt to the head or penetrating head injury. I would also say that menopause can cause that. Just saying. Everyone is at risk for a traumatic brain injury, and it is a cause that is a wide range or a short range cause, and it affects thinking, sensation, language, and emotion. Again, a menopause thing. During this next hour, we have Del Sol Medical Center trauma team here to help us better understand and answer questions about TBI. This evening's program is underwritten by Las Palmas Del Sol Healthcare, and we also want to thank the Texas Tech Paulo Foster School of Medicine for providing the medical students for us tonight. They always man our phones and they get the questions to us, and I want to introduce you really quick to Aaron Pines and Roberto Garcia, who are on our new camera, new set over there. So those are the two people that you're going to be speaking to this evening on the telephones. And I also want to thank, as each and every month, the El Paso County Medical Society for 21 years has been bringing this show to you. Good evening. I'm Catherine Berg, and you're watching the El Paso Physician. Thank you again. So we have the A team with us today. We have Stephen Flaherty, who is a general surgeon, and we also have Dr. Anoha. I love that. It's like Anoha. Anoha. See, and she's a neurologist. And then we have Vanessa Rado, who's a speech pathologist, a speech language pathologist. So we thank you so much for being here. We're talking this evening about traumatic brain injuries and all the different ways that can happen. I thank you so much for being here again. And Dr. Flaherty, what I'd like to do is, for the people at home, explain what you do all day, every day, so that the folks at home kind of go, oh, that's that guy. And we're going to do the same with all three of you.
Okay. So I'm a trauma surgeon and the trauma medical director at Del Sol Medical Center. My job is to meet patients in the operating room who have suffered injury, find out what's going on, and help them on the road to recovery. And oftentimes that includes some form of brain injury. Sometimes it's a mild brain injury, sometimes it's a very severe brain injury. We get them into the hospital. We partner with neurologists like Dr. Anoha or neurosurgeons as necessary, and also we bring in our speech language pathologists among other members of the team to help make sure that the patient gets the best recovery possible.
And sometimes these are ongoing, lifelong, and I don't want to call them issues, but just different ways of living and looking at how you're going to be doing things, and people around you too of helping you out in these situations. So I do want to focus on the different types of brain injuries and where we go from once a brain injury has happened, 5 years from now, 10 years from now, and then lifelong. Dr. Anoha, so explain to the audience what you do all day, every day.
Okay, I'm a neurologist, but my specialty is neurocritical care, so I'm a neurointensivist.
Say that nice and slow. Your specialty is?
Neurocritical care, so I work in the
neurocritical
ICU.
Care, gotcha, okay.
At Del Sol Hospital. I work at Del Sol.
Okay.
I'm also a private neurologist at Sun Neuro PA.
Okay.
So when these patients come in with injury, whatever kind of injury, as far as it's neurologic, I will get consulted. I'll see them for strokes, seizures, numbness, tingling, swelling in their brain, anything neurologic. And I think that's where I come in here, because these patients, as you know, they will have consequences of the brain injury. So I see them in the hospital, in the ICU, on the floor, and then after that in rehab, where, of course, Vanessa comes in, and then outpatient.
Okay, and Vanessa, that's a perfect transition to you. So you get to talk to people, and you get to help people talk. So explain to the audience what you do all day, every day.
So I am a speech pathologist at Del Sol Medical Center, and we're an acute care facility. We also have a rehab hospital on the top. And so all day I get to receive evaluations and orders, and I will go and assess a patient. If they are in the ICU, we're kind of looking initially at swallowing and voice, because some of them have been intubated due to respiratory issues or distress. And then we kind of just, like Dr. Anoha said, we follow them all the way through ICU, and then they're moved up to maybe our neuro-ortho floor, and so we'll continue to treat them there and then continue to advocate for them to go to the continuum of care, which would be inpatient rehab. And then there, our interdisciplinary team, again, works with them and then pushes them to home and independent, or if they need continued outpatient, we'll
if you don't mind, I'm going to kind of broaden your role this evening, and anything that has to do with rehab, I'm going to talk with you about a little bit. Are you okay with that? Yes. And if you can't answer it, you can't answer it, but just in general, I think that you kind of know that dance, so to speak. I do want to throw out some statistics, just doing some research, because there's a lot of information here that we may or may not know about as lay people, but traumatic injuries are estimated to be responsible for over 161,000 deaths in U.S. each year. Every day, and let's talk about Texas, every day there's an average of 32 trauma deaths in Texas, with motor vehicle crashes, suicides, and homicides topping the list of the causes. Children account for 25% of all traumatic injuries, and that extends then to trauma being the leading cause of death for Americans 35 years old and younger. Traumatic injuries is the third leading cause of disability for all Texans. So when we talk about, often we bring the show, and just so you know, that's from the National Trauma Institute, just to give some accreditation to that. We talk a lot in this show about different conditions that we may have. This may be a difficult show for people to call in with questions, because unless this has happened to you, you may not have a question about, oh, well, why is my heartbeat going faster when I go up the stairs versus, it's not a cardiology show. It's not a show that can be common to everyone. So I want to start off with what the most common brain injuries are. So we talked about, and years ago, I had a doctor on the air that says you can't call them car accidents. They're car crashes. So car crashes, I'm thinking, might be the number one reason that there's head trauma. Maybe not, I don't know. But Dr. Flaherty, let's kind of take it from there and tell us what are the number one causes of brain injuries.
Well, I think it's such a wide spectrum, because brain injury varies from something very, very mild like a concussion to a very severe injury where there's bleeding and swelling in the brain, and we have to do operations to help, save as much brain as we can. So I think, when you look at the entire spectrum and you consider what people are doing on a daily basis, the athletics and sports that they're involved with, the slips and falls that people have around the house, the occasional times that somebody stands up and bumps their head on the counter. I think that unintentional injury is certainly what's causing it. We're not talking about stroke, something that's happening from the inside. We're talking about an unintentional injury, and there is such a large amount of the mild injuries that it's going to be, I think, fall or sports that are probably combining.
We could do an entire show on concussions. I want to maybe touch base on concussions tonight. And when I say concussions, I mean sport-related. We talk a lot about 35 and younger. So I want to not stay away from that, but I don't want that to take over this program, if that makes sense. On that note, Dr. Anoha, I love your name. Let's talk a little bit about after there has been, and let's use the example of somebody falling in the kitchen on a granite counter, hard, and there is trauma. And we can describe what that was, but I'd like for you to maybe give us a range of issues neurologically that this person may have right then and there. They get to the hospital and then just kind of rehab what could be going on from there. It's a loaded question. So take that in any case study that you might have in the back of your mind that we can kind of look at.
Yeah. So, that's actually a typical case that will happen. Ms. Garcia comes in, she was found down by family members in the kitchen, not responsive, she's bleeding from her nose, she may have a fracture, and they bring her in the hospital. Dr. Flaherty is called because this patient is found down, some trauma. We do all the imaging studies, and then depending on the severity of her injury, she will go to the ICU. Chances are, because she was unresponsive, she will, have to be on life support and then be in the ICU. And depending on how big or small the bleed is, then neurology, neurosurgery will be contacted to see the patient. The main thing that happens, or the main concerns that we have, if she has bleeding, does she have swelling? Is the bleeding enough to squish her brain, basically cause a midline shift? Is she having seizures from that? If she's now unresponsive from it, is it because her brain is being pushed down, what we call herniating? Does she need neurosurgery to come in and, take some of the bone flap off, or will they just be fine if they took out the blood? She will have all these issues, and then apart from that acute phase, while she's in the ICU, she will have blood pressure issues because, when people are sick and their brain is, very important in autoregulation, we will have to work with that. And then on top of that, she will have all the metabolic issues with her sodium, with her magnesium, with her heart. Because right there in the subarachnoid space, you do have what we call the homunculus for the heart. So there will be so many complications from just Ms. Garcia was on aspirin or Coumadin and fell, bumped her head past that and had a big bleed.
Right.
Yeah.
And from there, again, that's loaded. So I'm gonna give Vanessa some time here, because then I'm gonna be bouncing back between these two for just a little bit. So since we're still on this case study in our imaginary world, this is a person who had to be put on life support. It's a big deal. And let's say it's about 2 weeks later. And again, we're just doing an imaginary person, but it's the idea of what may be issues that she or he is going through right now as far as rehab goes. Speech, of course, but then also, if there's issues everywhere else, because once the blood stops flowing, oxygen doesn't get everywhere, muscles get affected, et cetera, et cetera.
So falls actually are the #1 for brain injury. They comprise about 35% of all brain injuries. From 0 to 4, that's our, at high risk.
Okay.
And then 65 and over. So Miss Garcia is now at Del Sol, and she's in ICU. Definitely individuals will experience physical changes, cognitive communication changes, and behavioral and emotional changes. So yes, the interdisciplinary team will come in. It's your physical therapist, your occupational therapist, your speech language pathologist, of course in conjunction with our surgeons and physicians, and we will assess and identify what their needs are. Are they dizzy? Are they losing balance? Are they fatiguing quickly? Can they put on their socks? Can they snap their bra? Can they eat? And so we'll look at those basic levels and then provide them with a strategy to try to do it on their own.
Gotcha. Question here, Dr. Flaherty. So let's say mom, Tia Lorraine, whoever it is, when do we know that, this is an injury that we really need to go either call 911 or take her to the hospital? So she has fallen, hit her head. She's kind of dizzy, knocked out, just because that's what happens when we fall and bonk our head. So the question now to you and for the audience is, when or what do you look for in a person who may have had a bonk, whether it's on the field or on the table, or I tripped when I was walking my dog and bonked my head on the curb? What are you looking for? It's like, this is bad enough to go get checked out.
Right, so this is a common scenario. Something happens, we've rattled the brain, and maybe there was some temporary feeling of I'm not right, I'm not thinking straight, or maybe the patient was knocked out for a brief number of seconds and then came back. And so this is the question, do we really need to go to the hospital? So some of the more pressing signs is inability to interact normally with other people or with their environment. They're not thinking straight and acting straight. Maybe their speech is not right in the way they're able to form their words, or maybe they're not giving us answers that make sense for the context of what we're talking to them about.
Okay.
Other things would be development of drowsiness and sleepiness, at an abnormal time, development of nausea and vomiting.
And when you say development, are we looking at within hours, within days? What is and I know it's different with everyone, but if we're really trying to look and see what's happening here, could this happen within the next hour or two after the head? I'm going to call it a head bonk just because it's fun.
Right, so we don't know the rate at which the bleeding is happening. And some of our patients, especially our older patients, are on blood thinners or aspirin, and that makes it hard for the blood to stop. So somebody who hits their head and maybe has a very minimal amount of bleeding and then it stops, but another patient who's on these medications, that bleeding doesn't stop and it starts to accumulate. And that may accumulate over a couple minutes or maybe over a couple hours.
Okay, so we're looking at really you need to observe.
Watching over, the first, 6 to 12 hours, I would say, is the most important time, because there can be other subtle changes of thinking and things like that really suggest post-concussive syndrome, which are more happening over a longer term.
Okay.
But it's that initial period of hours that you're most concerned about.
I would like to use that then as a transition, Dr. Anoha, in let's talk about concussions for a bit. So, and let's just say it's a football player or a basketball player or someone who, even soccer player, they've had a concussion maybe at the age of 8. They knew it coming into junior high, coming into high school. They're still playing these games. So these are post-concussive issues. Some are mild, some are not so mild. And I think now the world is very good at recognizing that. Let's just say it's somebody from 20 years ago, and they're now 40. And they played a lot, and it's just like, man, are there issues later in life neurologically from having multiple concussive issues younger? Am I making sense when I say that? And what are they looking out for? I hear these stories, I read these stories, you watch the news, and what are parents looking out for?
So for the parents, the main thing they have to look out for is lethargy. And it's such a, little Johnny just doesn't want to do his homework. That's what it looks like. But no, he's sleepy because he has brain injury. He's post-concussive. Okay. And you're right, the repeat injuries are where you have problems, because over time, every time you have an injury, just imagine it's your skin. Every time you have a scar, it shrivels, it tightens, it looks different. So basically, multiple micro injuries to your brain, quote unquote, scar tissue to your brain each time, which the first few times it may seem like nothing, but over the years it accumulates. And they have a whole, post-concussive syndrome, dizziness, sleepiness,
So that's
headaches.
a syndrome. Okay.
Yes.
Good to know. So post-concussive syndrome, I'm going to take this a little bit different of a place right now. So it's not obvious, but when somebody has an injury, it happened. They fell down, car crash, etc. Let's just say now somebody has a brain bleed. It's not a stroke, but it's something that is now happening maybe from an injury they had a year ago or 2 years ago. And it's an injury that they bonked their head, either an accident or something, but nothing really happened during that time and may have sat there for a while. And all of a sudden a brain bleed occurs years later, months later. How and why does that? And the reason I'm bringing that up, we've had shows about different types of strokes before. There's the hemorrhaging stroke, the ischemic stroke, etc. And sometimes the hemorrhaging stroke, if it's called a stroke, there's just a brain bleed. How do brain bleeds occur from maybe a past injury? And then we'll go to some of these other questions. But it's just curious to me because you hear about it. Oh, so-and-so had a brain bleed, probably from, an injury he had last year in a car accident, etc. And I'll throw that to either one of you who wants to take it.
Well, I think that the first thing to realize is if the patient had a brain bleed a year ago and he recovered completely from that, chances are it's broken down, it's just fluid now, so he should be okay. But then he has another injury. If it's Ms. Garcia, who is 75 or 90 years old, and her brain is already shrunken, she's taking aspirin, she has a bleed, she may not come to the hospital or have as many significant issues as if it was someone else who is 45, just because their brain is still so full in the box. So any little extra, any little bleed will cause him problems because of the swelling and the tightness.
Gotcha.
So, those things, they will present differently just because of their age and the shrinkage and the amount of space they have to grow, basically.
Okay.
So we don't
Dr. Flaherty?
really get a spontaneous bleed due to trauma.
Okay, due to trauma.
It's not going to happen a year later that all of a sudden that trauma from a year ago now causes rebleeding.
Okay.
That's not a thing.
That's not a thing. So that's something
We gotta
internally there's an
re-injure the
issue.
brain.
Okay. Okay. Gotcha. Did you just say C in Spanish? C. I like that. So we have, I guess we kind of just addressed it here, because one of the questions I do have here for people at home is what is the difference between a brain bleed of an injury and a stroke? So if we didn't explain that well enough, in your opinion, do you think we did? If so, we can move on. But so maybe we can talk.
That.
Yeah.
He said that earlier when he said a stroke is internal, comes from something inside.
Right.
But I think the injuries we're talking about is something that is inflicted from an external source.
Okay.
So strokes are, things you're predisposed to, behavioral, familial, environmental, your diet, things like that. Mm-hmm. And you don't know when it's going to happen. Someone comes with a stroke and you say, oh, how did this happen? But the external injuries, you know what happened. He fell. He was in a car crash. Someone bumped his head. You can tell.
Okay.
And with strokes, the injuries that happen with strokes, most of them evolve over time. With a traumatic brain injury, it's usually a sudden,
Insult.
both of them could be sudden when you look at it that way. But when you do the testing, when you do your CAT scan, your CT angiograms, then you will realize that the person that had a traumatic brain injury could have just had maybe a dissection. But with a stroke, it was the cholesterol and all the cupcakes.
Okay. The cholesterol and all the
That
cupcakes.
stroke really is the result of disease. There's
Right.
some disease, whether it's high blood pressure or an abnormality of the wall of the artery that's going on, that then results in either lack of blood flow or sudden bleeding.
Okay.
Whereas the traumatic brain injury that we're talking about requires an external source of energy. Somebody got hit with a bat, struck their head. There's an energy source there that caused the problem.
That makes perfect sense. Taking things over to Vanessa, and let's talk about, and I don't know if it's a lot different for you, but brain injury, either way, speech issues. So you come into the picture now as your true profession, as a language speech pathologist. Whether someone's had a stroke, a different type of brain injury, are they similar in how you rehab them and how to get the muscles working again in the face and in the throat to rehab them back to somewhat normal speech?
So when we look at traumatic and stroke, they both fall under acquired brain injuries. And so you have traumatic and non-traumatic. So in terms of treatment, we would go in, assess them. If they had a stroke, we're looking at changes in language, so word finding issues. We're looking at poor auditory comprehension. If they've had a traumatic brain injury, we're looking at cognitive impairments. But the big thing is location. So the left side deals a lot with language, the right side deals a lot with your cognition. So if they have a left-sided stroke, we're anticipating that they're going to have a lot of language issues. If they've had a traumatic brain injury in their frontal lobe, we're going to be looking at executive functions, initiation planning, organization. So it is really very dependent on the individual, and there's not like a prescriptive, first do this. There's a lot of factors in play, prior level of function, were they productive, were they not productive, their age, their motivation.
Their motivation. And that's nicely said. And if I'd love for you to speak a little bit on the point, but once you are in rehabilitation for anything, it's the support system that is so crucial.
Yes,
and that might be nice for the audience to hear too, that whoever happens to be in your life at the time, that rah-rah, that cheerleading, that don't give up, and the motivation of just do it, get up and do what you need to do. That's so important, if you can speak to that a little bit.
Yes, absolutely. So brain injuries are actually kind of known as the silent epidemic. No one really hears about it or knows about it till it affects them personally, and you kind of touched on that earlier. So once you are impacted, it's not just happening to you, it really is impacting the entire family.
Right.
So support system is huge. And what we always like to tell our clients is it's a marathon, it's not a sprint. So it's not going to be 2 weeks and you're going to go back to being the way you were before the injury. It is a process, and so the whole interdisciplinary team really looks at all the different areas where we can get them to require less assistance, reduce burden of care.
Yes, Dr. Flaherty?
Augment that a little bit. So the importance of the support network really has to start early. And one of the things that I think will be good for our audience to know, so that they can prepare to how to help people, is they need to be ready early. So they need to be taking care of their own sleep hygiene and eating habits and keeping the home running and making sure the bills are being paid, because this is going to be a marathon. And we need that whole support network to be strong and ready to go to help.
Right. You have to take care of yourself to be able to take care of somebody else.
Yes, that's right.
Yeah. I do want to mention that this is streaming live on Facebook, and if you'd like to ask questions, you can also do that through Facebook. And this is a question that was asked through somebody on Facebook. So what are some of the things that families should be aware of in terms of personality changes when it comes to traumatic brain injuries? And we can either break it down by stroke or not. I actually like to keep it, though, with, like you said, an outside energy event. I'm not sure exactly how you said that, but personality changes, it doesn't ask if it's immediate or ongoing. So maybe we can talk about immediate with you, and Dr. Onoha maybe with ongoing personality changes, if that's the case. Because you would think personality is that something that happens, but that's within ourselves completely. So Dr. Flaherty, if you'd like to start with that and then punt over.
So this actually is one of the more challenging events that we have to deal with on the in the ICU for the severe brain injuries, because me and my partners, we're the ones who are there all the time in the ICU handling this. And one of the most common things that we see is that initially the patient is unresponsive.
Right.
And part of that is because of the brain injury and the effects of the swelling and the abnormal architecture that's happening in the brain. Some of it's due to the fact that I'm giving them medicines to keep them sedated so that I can appropriately take care of them. And that's sort of the initial phase. And then as we start to see the patient get better and we decrease the medicines that are causing sedation intentionally, we start to see a phase that they go through of not being able to control their own thinking and thoughts and be reasonable, and they become very agitated.
Oh, I'd imagine, yeah.
And that agitation is very difficult for everybody. It's very difficult for family members to see and watch. It's actually a challenge for us to take care of at times. It can be very challenging to find the right medications that will allow the patient to be calm without over-sedating them to impair their recovery.
Right.
So that's one of the early changes that we see.
And that's not something that you can easily explain to the patient, I'd imagine.
They are not able to understand that.
Yeah.
It's not easy. They are not able to understand that.
Okay.
That's part of the injury that has happened, is they are not able to understand.
And Dr. Onoha, going forward into rehabilitation from that point on, what can you add to that? Suggestions for family members, even maybe people who have had brain injuries that are watching the show, what to expect going forward, etc.
So I think that one clear distinction is, if the patient has had a stroke, it's easier because it's a vascular territory. As Vanessa was saying, it's the frontal lobe, it's the right hemisphere, it's the left hemisphere. With traumatic brain injury, you don't have that luxury.
Okay.
Because
right.
when you strike your head, like if you look here, the strike might be at the back, but the part of the brain that suffers is the two frontal lobes. You can have what they call a countercule injury, where this is where the impact was, but the injury is on the other side, or it's underneath the brain, or multiple facets of the brain tissue are affected. And therefore, the patient will have multiple areas that are just not functioning or responding. Behaviorally, they have an issue. Speech-wise, they have an issue. someone who was very calm and sedate before, he wakes up, he's swearing, he's pushing at things, he's pulling at all the, medical devices. It's very difficult for family to deal with. And that can be a struggle. That can definitely be a struggle. Well, of course, we try to sedate them, but you cannot sedate them forever, because at this point you're trying to wake them up to get them to go over to Vanessa to start getting therapy. But
so in the meantime, and this is a difficult question to ask, because I'm thinking, how does one keep them from pulling everything out? Do you have to tie the arms down sometimes? And I'm asking that because this is a medical show, and when that does happen in the hospital, there's reasoning for that. You're not just being mean or torturing, or it really is for the better good of everybody. But I just like being direct as possible, and maybe Vanessa, you can talk a little bit about that, because I don't know how quickly you come into the picture after an injury. Is that, I'd imagine while they're still in the hospital, obviously, but are you dealing at any time with someone who's just,
yes.
And talk a little bit, I don't know how to describe that, but just mad.
As soon as we have a trauma activation and they are now stable and in the ICU, we at Del Sol, we round daily on all of our trauma patients. And so that's when our trauma doctors would say, hey, this is a good time to go in. We're reducing the sedation. Go in and check them out. So we'll go in, we'll do an assessment, we'll identify, what they can and can't do, what their barriers are. In terms of behavior, yes, if their awareness, their insight is impaired. And so we can't tell them, don't do that, don't do that, don't do that, because they don't understand why they can't do this thing that they used to be able to do. So they've also had a period of loss of consciousness. The last thing they remember is not being intubated and taken down for surgery. The last thing they remember is probably what they were doing prior to the injury. So in their mind, they can walk, they can talk, they can leave.
They just don't get it. Yeah,
right, and they tell us all the time, we're going to leave. And so we really try to address the behavior, try to build awareness. We try to put in place like a behavior plan to redirect them. And we do a lot of family education at bedside, in the ICU, all of our rehab team, PTOT and speech.
Now, pardon my ignorance on this, because I would think that if it is thoroughly explained, as I'm sure you do, to the patient, the cognitive, not behavior, but the ability to cognitively understand, does that start to get better? Is that a repetitive thing? Is that, and Dr. Flaherty, you were saying they just don't understand it. Is there a certain point that's natural where it's like, okay, I'm starting to understand now that I'm not going to be able to walk for the next couple of months or whatever? And I know it's different with every person. I respect that completely. But just maybe in your experience,
absolutely,
how many times do you repeat? And that's, I guess, where the family members are trained, et cetera. Is there a point where it just starts to sink in?
So another big part of our interdisciplinary team are our nurses. And so our nurses are in there every day. And so definitely we have a lot of communication with them, and they implement those behavior plans, that repetition, that redirection. Definitely family is also redirecting, but we do speak directly to the patient because we want them to have their autonomy. They are still an individual who happen to have had a brain injury or a traumatic brain injury, and so we give them that autonomy. We continue to talk to them. If they get upset, if they respond negatively, we just redirect. Maybe we might have to step out for 5 minutes, give them some time to reset, and then go back in. Sometimes with individuals who are having memory impairments, which is typical after a traumatic brain injury, you can't just tell them.
Right.
You need to give them some type of strategy or compensatory strategy. So we might write something down. Don't get up, you will fall. We have bed alarms, chair alarms. So all of those are auditory, verbal, written feedback for them to kind of cue them, oh, I'm not supposed to be doing this.
My hat's off to all three of you and anyone and everyone that works on a team like this, because I can imagine we're talking about the frustrations to the patient and to the patient's family. But the frustrations that you all must go through and dealing with this. And you were just saying, you know, sometimes you need to walk out for 5 minutes to give them some time. I'm selfishly thinking, man, I think I'd want to walk out to give myself some time too. And so, again, to everyone at Del Sol, that's a fantastic, and thank you for all the patients that are not able to say thank you. I can imagine that's difficult. So, high five for sticking in there. Question here from the audience. Can a repeated painful trauma to the body result in an injury to the brain via inflammation in some or causes? So maybe this is a trauma, let's say it's a car accident, and they didn't bonk their head, so to speak, but somehow, you know, other parts of them got hurt, but somehow is there a way that the brain can be traumatized by that? And I don't know, I'm not mean psychologically, I'm talking physiologically, but it's a question from the audience, so I thought I'd try to honor it. Dr. Anoha, you're nodding your head, so that's what you get. That and you're wearing cool eyeglasses. So that's why you get this question. It's a tough question. But maybe they hit their shoulder really hard that may have resulted to a jar to the head or something.
Right. And I think that question, it's more likely going to be from physiologic injury.
Okay.
Because assuming you had trauma to your belly, say you lost a lot of blood, there's no injury to your head per se, but in the process of losing blood, you compromise cerebral perfusion.
Right.
And in compromising cerebral perfusion, that's like a global global brain injury. It's like a trauma to your brain. Or let's say you injured your liver is not processing ammonia, for example. And then you have all these abnormal metabolites creeping around your body.
Right.
That's toxic to your brain.
Okay.
So there are a lot of apparently non-brain injuries that can definitely cause you to have traumatic brain injury presentation.
Okay.
Yeah.
I'm glad I asked that then. At first I thought, well, I don't know if I should ask that question, but that makes perfect sense because you have all kinds of other functions that obviously hook up to the brain.
I just wanted to
Yes, Vanessa.
jump off of that. So we were talking about the umbrella of acquired brain injury, that traumatic and non-traumatic, and so sepsis, infection, tumor, metabolic changes, stroke, that would fall under non-traumatic brain injury. So it's not anything directly hitting or striking your head, but your brain cells, they are metabolic, and so if there's any changes, something going on.
And that would still be considered some kind of an outside source of injury. Would that be correct, Dr. Flaherty? Or is that one of those more complicated?
Disease.
It is back. Okay.
Disease and internal manifestations
Of something else that happened to the body, not directly to the head. Question here from the audience. We were talking about symptoms earlier. So this question from the audience. Viewer wants to know if you check someone's pupils for equality and reactivity to light, is that a way to diagnose a possible brain injury? So this sounds like someone who may have been told that in the past, have read that, maybe it's concussions, but etc. Dr. Flaherty, would you like to take that one?
Yeah, I would say absolutely yes.
Okay.
There's a small percentage of people who have slightly different pupils on each side that's just normal. So
I'm
don't
that
go
person.
erasing everybody to the
I used to
hospital
think that
just
was
'cause
really
it's a little
weird.
bit off. Right, but in the context of somebody just had some injury to their head,
Right.
and now you're noticing a difference in the pupils, especially a dramatic difference, that would absolutely be a reason to go promptly to a hospital for
In
evaluation.
general, is it a delay when the pupils get larger, smaller? Does it matter? Or are you just looking for something that's not normal? Because I don't know if I'm looking at you and I'm thinking, oh my gosh, his pupils are rather large today. I don't know if that's something that you would think, or if your eyes are dark, it's harder to see
It's very difficult to
if
see.
the pupils are larger or not.
Right. So the time course that it could happen depends on how the injury is evolving.
Okay.
You know,
Gotcha, that
whether
makes
there's
sense,
more
yeah.
bleeding, more pressure, more swelling that's happening, so it might not be noticeable now, and then as the effects of the injury take place, and most typically I would say we see dilation.
Okay.
Because
Okay.
it's just failure to
It's
constrict,
dilation
yeah.
because the nerves can't control it.
Gotcha. Makes sense. Dr. Anoha, I'm going to send this to you. Can psychological trauma cause let me see, I'm reading this cold. Can psychological trauma, like being threatened, cause brain damage? Is a question from the audience. That is more, I don't know if that's physiological enough. You can address it, but again, I read that one cold. I don't know if we want to.
If psychological
trauma, like being threatened, can that cause brain injury? or brain damage. And I think maybe that's probably more for a psych show.
Were they physically
but-
threatened, like someone choking them?
Well, let's talk about that, so that there is a physical, again, outside force threatening. So maybe we can talk about that, and it causing some kind of brain damage, maybe in the loss of oxygen, with the loss of blood going to the brain for a while, etc. Maybe we can take it from that perspective.
Yeah, I think there has to, psychological trauma in itself will not cause brain injury that we will visualize on it. Because when you talk about traumatic brain injury, there is, as he described earlier, there is a jolting, there is some sort of rattling of the brain.
Right.
I'm not sure how psychological trauma will cause it, except of course you try to inflict some type of injury.
Okay.
I'm sure
Dr.
there's a
Flaherty
great-
had something
I'm sure
that-
there's a great research question there as to whether PTSD is brain
Traumatic.
damage.
See,
And
That's a
what
great
exactly
point.
is happening at that point, and what's that continuum of injury versus metabolic change that it all
Yeah.
results in abnormal brain function. So can psychological trauma cause abnormal brain function? Yes, we call that acute stress disorder, or if it lasts
Right.
long enough, post-traumatic stress disorder.
Right.
But it's usually not what we're talking about when we're talking about brain
So I
injury.
guess then a question would be, that would just naturally come to my mind, how would one diagnose that physiologically? Probably couldn't. If you did a scan, or I guess
mean
that
the
would not
trauma
be
or the
trauma.
psychological
Yeah, the
insult?
psychological. Yeah. I mean, I don't know. I'm just thinking if PTSD is a perfect example
So
with
you're
that.
getting into high-end imaging,
Yeah.
like functional
Yeah, there were a lot of
MRI and
functional
all
imaging.
kinds of
Mm-hmm.
esoteric
scans
things that
and PET
really
scans.
exist on the research fringe right now would be
Okay.
my answer.
Okay. So we'll have the show again in 2 years,
There you
and
go.
we'll have that answer.
we will have that answer.
I say that a lot. I mean, that's one thing I love about the show. We've been doing it so long, and every time we have a show about a specific subject, it changes dramatically from one year to the next, just because of the research and things that people have found. Let's talk about diagnosis. So when someone has an injury, and I don't even want to throw an example out there, but let's say somebody has a brain injury. It's obvious. They're coming into the ER, they're bleeding. What immediately do you do, or the ER doc do, to figure out what the heck's going on here? Is there a lot of bleeding in there? Is there a chunk taken out of the brain because of something happening? So talk about a couple of ways that you all diagnose injuries.
So the first thing that we do is a good old-fashioned physical exam.
Okay.
We assess how is that brain functioning, affecting the person right there in front of us. But really, that's just a very gross assessment of what's going on, and we can't tell you exactly why that's happening. So it really then rapidly transitions into imaging of the brain, which is a CAT scan. In the acute setting, our primary go-to diagnostic modality is a CAT scan.
Okay.
And that shows us the anatomy of the brain and tells us if there is structural change to the brain or the contents inside the skull.
Okay. Now, take that a step further in Surgery Man. Now there is bleeding and there's swelling, and I need to relieve that. What do you do then at that point?
Right, so we have some very set algorithms that we go through to try to change that for the better for the patient. There are some conditions that we know immediately when we look on it, on the CAT scan, that will require an operation. If there is a large collection of blood sitting on top of the brain, then the only way to fix that is to go underneath the skull and take that blood out.
Now, when you say on top of the brain is bleeding from the injury.
Well,
And
not
to find,
necessarily.
okay, so I
So
guess
there are
that's my question.
veins
How do
and
you find
arteries.
where do you, yeah, okay.
So underneath the skull, so we have the skull is a bony structure that surrounds the entire brain, and this is why we have such trouble with brain injury, because there's no place for anything else inside of this
Right.
bony structure except what is already there. A little bit of blood that's inside vessels, the brain tissue itself, and a bit of cerebrospinal fluid.
Okay.
If we make the brain bigger, or we put any extra blood or fluid in there, something's going to get damaged because there's going to get pressure on it because there's no way for this to expand. So sitting on top of the brain, there's a network of arteries and veins. And sometimes that trauma, that energy that's applied, can either break the skull and cut the artery or vein underneath it, or the force, because the tissue actually moves underneath it, can tear the vein.
And this
if
is
that
all
vein tears, then
underneath the
that's
skull without the skull being
underneath the
broken.
bone. It can happen without the skull being broken.
Okay, so we're going to call this guy Mr. Knucklehead. I just think it's a perfect name for him. So now we have Mr. Knucklehead, and he's been in a car crash, and his skull is not broken, and there's trauma underneath there. Do you need to go in there and cut some of the bone off to allow this swelling to either decrease or to, I don't know, I guess
that's a great question.
In days and
I'm going to speak
induced
on behalf,
comas, etc. Go for it.
I'm going to
Yes.
speak on behalf of my friendly neurosurgeon, who's
Okay.
the true subject matter expert, but we
Okay.
work so closely together that I can give you a pretty good answer on this. So sometimes there is there's nothing inside the brain that the neurosurgeon can repair or fix, but there is swelling.
Okay.
We will try at first to medically reduce the swelling, and between medicines and ventilators and various things we can try to do that. But if we cannot reduce the swelling inside the brain, then the neurosurgeon might, again depending on some other factors, decide that the best solution is to cut off a section of the bone to release the pressure.
Okay.
Or we might decide that we're going to sedate the patient so deeply and we're going to put them in an induced coma.
Okay.
Those are all very esoteric discussions that happen in collaboration between the trauma surgeons, the neurocritical care doctor, and the neurosurgeon.
Okay. And
sometimes it's much different, and there's just a glom of blood sitting on top of the brain, and that's the easiest.
On top of the brain, but still under the skull.
Under the skull, but on top of the brain.
Is there a drilling situation
And
there?
so-
I mean, I just think of all the things I've heard throughout the years, and I'm just morbidly curious now. So would that be a way where you can drill into the bone to relieve or to take the blood out at that point?
So that's what they would do, is usually they would lift out a little window of bone, and to do that they first drill in some holes, and then they connect the dots, take off a little window of bone, take out the blood clot, find what was causing the bleeding, stop it, and then put the window of bone back on.
Okay. Find what was causing the bleeding and stop it. I feel like that's such a complicated...
Just like that.
Oh
right?
my goodness, let's see if we can find
find
where
where
this
the
is
bleeding
going
and
on.
stop it.
So one of my questions as you were speaking, I didn't want to interrupt you. When the swelling is occurring, is there a CAT scan after CAT scan after CAT scan to find out how much that swelling is occurring? How do you keep an eye on that? Is that hourly, at the first day or two?
So we will often ask the neurosurgeon to put a special monitor inside the brain
Gotcha.
to measure the pressure
Okay.
as an indicator of that swelling
Okay. Inside the brain, again going through the skull.
going through the skull.
Gotcha. Okay. Goodness gracious. We have a 14-minute stop point before the show ends. I didn't tell you guys before the program started, but what I like to do around this time is kind of stop questions from the audience. We have plenty still to go. But see if there's something that you all want to talk about that we haven't touched base on yet. Because sometimes the show ends and it's like, oh man, I really wanted to say A, B, C, or D. And Dr. Anoha, you get to go because we just had Dr. Flaherty speak. Is that putting you on the spot?
No,
It
it's
is.
not at all.
Okay. Because I feel like with neurology, oh man, that's 18
It's
shows
so long.
worth of information.
No kidding.
Yeah. So feel free. We've got plenty of time, and just go for it.
I think that the most important thing I would like to say to the audience is when their family members have traumatic brain injury, they see something different from what I see. So I go in there and they say to me, oh, little Johnny has been following commands. He listens to me. He's calm. Can you tell them to take off all the sedation? Can you tell them to take off the restraints? Well, what they are failing to understand is their voice is familiar to little Johnny.
Right.
He recognizes their voice. It's soothing to him. So he's calm when they're there. They touch him, they talk to him, and he responds. Well, I go in there in the morning like a banshee and I'm yelling, Johnny, Johnny, you got to wake up, open your eyes.
Right.
He's not going to do that for me. So sometimes it's not that the physicians are trying to be mean, we're just not getting the response they are getting. So honestly, I want to implore them to hang in there with us and understand that our voices are not familiar,
Right.
and the patients with this significant injury cannot always respond the way we want them to respond or the way the family members think they always respond.
And that's a beautiful thing to put across, because again, you are in a complete different position and they don't always get to see that. And that's why, again, I'd like to give a high five to everybody that really anyone in medicine. I mean, it's frustrating all around. And sometimes I like that when we do this show, and it's interesting too, because the guys here at KCOS, as you can see, we've got a little bit of a different look. We're trying to incorporate Facebook. We're trying to do a lot of things. My goal is to present who we have on the panel as real people, as human beings who also have feelings, and you need to take 5 from the room for 5 seconds, But that matters in this day and age, because in the old days, it's like, why do we not want people wearing white coats? It's that white coat syndrome. They walk in and you're talking, you don't understand a word that's happening. So when we are able to tell the audience what your perspective is as a human versus just a doctor, I think that's so important on this program. And that's why we do this whole 15 minutes left thing. On that note, you're nodding and smiling. So Vanessa, tell me what you would like to get across to the audience that we may not have spoken about yet, or something that you'd like to reiterate that we've already spoken about.
Oh gosh, so much. So
much? Yes, I know.
Really, I'd just like to talk to the individuals who've had a brain injury and their family to definitely continue to look for help and support. There are support groups in El Paso. There is the Brain Injury Association of America. On there you can find caregiver tips, patient tips, how to return to work, what you're kind of looking for before you return to work. I mean, definitely come and see us at Del Sol, and we can give you some information as well. We always tell our patients when they're leaving out the door, we're so excited, but we say, come back and let us see how you're doing, because traumatic brain injuries definitely pose a huge loss to the individual, society as well. So you have an individual who's productive and working and paying their bills, and they were a mom or a dad, and now unfortunately they have some impairments or deficits that impact their ability to do that at the capacity that they were doing it before. Not to say that they will never be able to do it, but again, as they're going through this marathon. So definitely ask for help.
Right.
Look, there is a lot of information out there.
It's brave to ask for help, far braver than not. I appreciate you saying that. That's a good way of putting it. Dr. Flaherty, how about you?
I think what I'd like to say is that really there's a difference between a hospital that takes care of people with injuries and a trauma center. So a trauma center has gone through a very specific process to make sure that we meet national standards for availability of resources and are following nationally recognized patterns of care. And that represents a huge commitment on the part of Del Sol Medical Center and the Las Palmas Del Sol health system. And everything that they have invested to make sure that everybody is here ready to take care of these traumatic brain injured patients from the time they arrive throughout their entire hospital course and into rehab.
Right.
And that's just really so important. And it enables us to do things like have multidisciplinary rounds every day where, we have got 8 people representing all different aspects of care of the patient, standing and getting in sync with each other and saying, you know what, Vanessa, today's not a good day for you to see this patient. He's not ready yet. But then 2 days later, she's right there. Vanessa, today's the time to start getting you involved.
Yeah.
So that's huge. And the other thing that I'd just like to do, I'd like to bring out a piece of what our rehab service team, so PT-OT speech, are really so important in all patients, but maybe especially so in the brain injured patients. And so they're consulted in all of our brain injured patients. Even if I don't think that they have a cognitive impairment or a physics, the way their arms and legs are working, really because they are so expert at identifying small and subtle changes, we have them see everybody. And Vanessa and the other speech language pathologists do such a great job at the neurocognitive assessment, and will come back and say to me, you know, Dr. Flaherty, his memory is impaired. He's he's not able to be calm, cool, and collected. He's a safety risk for going home.
Right.
Or this patient, has some subtle visual impairment and is abnormal balance, and the strength is abnormal in this place, and is not safe for being home in these surgeries. That's really a huge piece of what happens in the hospital.
And that could be too, the family may think he's ready, but really if he's not. And I'd imagine that there may be some not disconnect, but disagreements perhaps with that sometimes, and that might be a hard thing. So again, your message to everybody at home would be, let's take 5 and really check all this out. We've got about 5 minutes left. I do want to tell the audience once again, sometime the show goes super duper fast. You can watch it again, segments on it on Facebook. Just go to KCOS TV. You can also watch us again on kcostv.org. Just go to watch programs and find the El Paso Physician logo, and also on the El Paso County Medical Society website, and that's epcms.com. So if you're just tuning in now, or if you just want to watch a show again, and I think that's so important. So many people ask about that. Question here from the audience. Let's talk about Guillain-Barré. I know a person who had this condition, not a disease, but the question is, can this cause brain trauma? Maybe we can talk quickly about what that is. It's the myelin on the nerves, if I understand it correctly. Just it goes away for a while until it comes back. And actually, Dr. Onaha, I'm going to ask you about that. Can that cause permanent brain damage? Guillain-Barré syndrome?
So it does not affect your brain, but the way it can affect your brain is these patients have muscle weakness, they have loss of sensation in their feet, in their arms. In that way, they can suffer more falls than you and I. And we know that falls are the commonest cause of traumatic brain injury.
Okay.
So that's the way it can cause traumatic, but by itself, it does not affect your brain.
Okay. Good to know, and you're right, because it's all about just trying to regain all those senses. Question here from the audience: do you have any recommendations in terms of managing headaches for individuals who have undergone several concussions? So this is not like I have one now, but I've had several in the past. There's a result of headaches futuristically. Question from the audience: who would like to take that one?
That
Anyone?
would be post-concussive syndrome.
Okay.
Yeah, and it's an interdisciplinary management. There are medications we will give them, but those medications will only manage some of the symptoms. They have a whole array of things that will go wrong: the headaches, the dizziness, the loss of coordination, the memory problems, the loss of functional status. Not one medication can manage that.
Okay. If you had to recommend over the counter,
I was going to say maybe they might be able to manage it by changing their environment, so decreasing screen time, turning the lights off, kind of mentally preparing themselves before they're going to go do something, trying not to do 10 things in one day, maybe 5. So those are all compensatory strategies that they can use to reduce that.
Spoken like a true therapist. I like that. Yes, Dr. Flaherty, you had something
I was
to
going to
that?
say brain rest.
Brain rest.
Just keep screen time. Don't be reading. Decrease the amount of noise. Get good sleep hygiene. Sleep well and eat well.
Okay. Nicely said. So again, we are about to wrap up on this program. So I want to say once again, thank you so much to Las Palmas del Sol Healthcare for underwriting this program. It's always interesting to talk about brain injuries in general. It's such a wide gamut. You've been watching the El Paso Physician. I'm Catherine Berg. Good night.